Hello, everyone. I'm Frank. I'm a PhD student studying pharmacoepidemiology at the University of Oxford. It is an honor to have such a great chance to present my research work and the learning from the big OTC community. In this study, we aim to assess the risk of COVID-19 outcomes in patients treated with osteoarthritis or back pain treated with ibuprofen. Frankly, this is my first experiences of using common data model and relevant techniques. So please feel free to interrupt me if you have any questions. So some of you may or may know that at the early stage of the pandemic, French doctors reported 4 COVID cases who previously used ibuprofen and later on developing into the serious disease. This clinical report later on was backed by the France health minister. He said on tweet that we should avoid use ibuprofen. And after that, lots of news, rumors, and disputes regarding the use of ibuprofen, not only for the management of COVID-related symptoms, but also for other conditions like chronic back pain. So there was an urgent need to address this public health concern about the safety of ibuprofen use in the context of COVID-19, or more specifically, when we formulate this into a research question, that is, would ibuprofen medication increase the risk of COVID-19 susceptibility or the severity? As far as I know, according to the OTC defined the 3 broad type of research, this one should fall into the typical course of estimates research. To infer causality, we know there was a gold standard, that is randomization. However, this approach is not feasible for every situation, and in our case, the observational study should be a rational choice, which saves time and money. And most importantly, if performed rigorously, results from it can be more generalizable to wide population and transferable to the real-world settings. When we consider this study, we realized there was some challenges inherited in the research questions and the data that we need to consider carefully in order to approach the causal estimates. The first is ibuprofen is a typical over-the-counter medication that is widely used with broad indications, which means the patients will use it to treat various disease and conditions. And also in terms of COVID outcomes, the COVID-19 was likely to underdiagnosis, particularly at the early stage. But what concerns us most is the potential reverse causality issues, because it is common for people to use these drugs to treat COVID-related symptoms such as fever, and then later on report the COVID diagnosis. And lastly, the COVID is the lower disease, which means it's more difficult to identify the potential confounders based on the clinical knowledge. So to tackle these issues, we adopted several strategies. For example, at the design stage, instead of comparing it with lung users, we selected several active comparators, such as other lung-selective NSAIDs, COX-2, and paracetamol, because all of them share similar indications with ibuprofen. And also, we restricted the patients into the OA and back pain patients with a consideration that most of them are regular or chronic use of ibuprofen and were therefore less likely to switch between different drugs than the new or intermediate users. To solve the potential issues of reverse causality, we specifically designed a pre-pandemic cohort in which it is unlikely that take this drug for COVID-related issues. And lastly, we included both adjudicated and unadjudicated claim-based databases. By doing this, we hope the underdiagnosis issue could be to some extent mitigated. Furthermore, at the analytical stage, we used the large-scale propensity score matching to minimize the residual confounding, and we focus on the treatment period to reduce the misclassification after the index date. And what's more, we also quantitatively assessed the likelihood of the uncontrolled bias by using the data-driven negative control experiments and use the empirical distribution information to calibrate our final estimates. So to sum up, in this study, we finally constructed 12 pair of cohort, which is one target drug multiply 3 comparators, 2 study windows, and 2 databases. Here are our results. The 2 gray arrows show the pre-pandemic and the pandemic cohort. What we can say is that because these drugs were so commonly used, we got a quite amazing and large sample size. For example, more than 1.5 million users of ibuprofen versus COX-2 pair, and nearly 4 million users of ibuprofen versus other NSAIDs, and similar numbers for the ibuprofen versus paracetamols. These figures are even almost doubles for the pandemic cohort. In terms of the performance of propensity score matching, it seems works well with quite a decent overlap of the propensity score between the comparison groups as shown in the top figures. And also there were quite a lot, although there were quite a lot of differences for the measured covariates, they were all well balanced after the matching, with the standard mean differences less than 0.1. Here is an example of the survival curve for the comparisons of ibuprofen with other non-selective NSAIDs in the pre-pandemic cohort for the on-treatment during the on-treatment period based on the open claim databases. This largely overlapped curve suggests the similar risk of COVID outcomes between the comparison groups. However, when we check the distribution of negative control outcomes, we found that only 87% of estimates coverage the non-effect, which is a signal of the existence of the residual confounding, and more specifically, most of these significant points are greater than 1, as shown in this circle, which likely bias our final estimates to risk factors. So we applied the empirical calibrations, and after this method, the confidence interval of hazard ratio for all the valid estimates cross 1, which is consistent and reassuring. So in summary, in this study, we comprehensively evaluate the safety concern of ibuprofen use in the context of COVID-19. We created a nearly 10 million cohort of patients with osteoarthritis and back pain, and we compare it with multiple alternative analgesics, and using the advanced methods to control for the residual confounding and bias. And we do not find the evidence of ibuprofen would confer the different risk of COVID-19 outcomes, and suggest that patients with arthritis or musculoskeletal pain should use the ibuprofen as indicated. But we acknowledge this result should interpreted in with the limitations that all these drugs are used over the count, and the potential misclassification might underestimate the true risk if there are. And luckily, after 1 year of peer review, this study has been recently published in Drugs. And that's all for my presentation. Thanks for your listening.